First of all, I'm absolutely delighted to present Pam Simpson, who's been an absolute stalwart of MBE for many, many years, and has always just been really on point with the things that she states. So I'm really looking forward to listening to Pam now. So Pam's interest in the design and implementation of work-specific moving and handling training strategies. She's got over 30 years' experience of designing and delivering training courses to the public, private and voluntary and charitable sectors. The emphasis is on evidence-based, person-centered approach to complex decision-making. Pam carries out many legal reports and works part-time as a physiotherapist in clinical practice. So welcome, Pam.
Good afternoon, everybody. I'm very nervous about this because I know that the HOP series is a hot topic and that many people in the room are equally expert. I must look at what stalwart means. I suspect it's something to do with age. Thank you for the introduction, Simon. So yeah, I'm here to tell you about HOP7, the latest in the handling of people series and where we're up to now and the progress and content to date. It's been a very long time coming. This publication was first commissioned by Back Care back in 2017, which, yes, is a long time. Back Care, as you know, is a charity and at times a struggling charity. The HOP series is quite a large part of their income, and they care about it very deeply. They've had a change of personnel, they've had a change of trustees along that time, as many of us have had many changes since 2017. Back Care's aim was to increase the scope of the publication, increase its audience to not just those of us who are passionate about the subject who are in the room, but all of those people who are patient handlers, although they don't call themselves that. So every professional, every carer, every support worker. And when we listened to Jackie first thing this morning, our message doesn't get out to as many people as we would like it to. And Back Care had this ambition in mind when originally commissioning the book. It has further ambitions for the book as it goes along in terms of digitising some sections, getting some sections more easily accessible, and increasing international exposure. So it does have broad ambitions going forward. How much those will come to fruition will depend. And those of you who've heard me before will know that I start many answers, well, it depends. So we just have to wait and see. But in thinking about how I was going to explain the successes and the challenges of this publication today, I've sort of come up with 12 Ps. Now, I'm not going to explain them because I'm sure that you will get the nuance behind every one of these. The challenges we've faced in the project since it began start with people. We're all different. And if any of you have tried to decide anything by committee, you will know how difficult that is. So people. Promises. Promises kept. Promises not kept. Difficulties. And perception. Perception of what it is actually that you've promised to do. And whether your perception meets the person's perception who asked you in the first place. Personalities. Publishers. Payment. Payment between the publishers, the commissioners. I can't pay for something I've not got. I can't produce it till you give me some money. Progress. We made progress, vastly, and we were coming to the conference here in 2019, and we were sort of on target to launch, ready for that, when I agreed to do this plenary 2 years ago. Pandemic. Now, I'm not using that as an excuse. That's easy to do. However, we all know what happened to health and social care. Most of us were really in the middle of that. So new ideas, new evidence, new case law. And there has been. There's case law about the Coronavirus Act, would you believe? So we then had to return to the authors whose work had been submitted and peer-reviewed and say, well, is there anything new? Because if we publish now, we might be out of date. Pause. Persistence. Peer review process. Promises. And then to production. And that's where we are now, thankfully. We're getting towards the end of our Ps. There's some little process to complete, but on the whole, we are ready. Publication! And those of you who've looked at me over the last day and thought, God, she's aged, then I do hope you'll have a little sympathy. Actually, though, I looked at Mike Frey yesterday and I think he looks 10 years younger. So we have got very close to the end, and publication is hopefully by the end of November. So that's probably only about 8 or 9 weeks to go. So time for a silly giggle, only that doesn't begin with P, so I won't do that. Okay, so it's rather a poisoned chalice to stand here, because many people will think, well, why not me? You know, why you? I've got just the same experience, I've written things, I've edited things. Well, that's just the way the cookie crumbles. I didn't ask for this. I was approached by Back Care, so I took it on, and here I am. However, there are a few anniversaries. It's 40 years since the first edition. It's 10 years since the last one. Many individuals, businesses and organisations have had to review their past, consider their future, including health and social care on every level. 2018 was another anniversary. It was the 25th anniversary of the pack of legislation that included management of health and safety at work and manual handling operations regulations. Most people working now have not been through all of that change and all of that evolution, don't really understand how we got to where we are now. And this is not the time to start explaining. This is the time to look forward. This publication is an emphasis on evidence-based decision-making. So we went to HOP7 in 2005. That's when, I think, when patients became people. Is it? Is that when patients became people? Thank you, front row. And then, of course, in 2011, we had HOP6. Now, HOP5 and HOP6 are still as cogent and as relevant and as important as they have been all the time. This is not a new publication to replace. It's a new publication to enhance, to add on to make us think a bit further. So please don't think just because there's something new, what's there before is not relevant. Though as we go through this publication and I explain to you, there are chapters that are in HOP5 and HOP6 that are just as important as they ever been. But now we're looking at empowerment. We're not saying this is what you should do. We're saying this is what you should think about. These are the tools you should have in order to make decisions. So it's about empowerment of two lots of people. The people being handled and the people doing the handling. This is a person-centered publication. It's different, but it complements. So the editorial team and the authors recognise, we all are recognised as experts and innovators, and we're volunteers. And we all know how it's easy to give enthusiasm and hard to give time. And that's been a big problem for all of us. I know people used to say, if you want something done, ask a busy person, but I've now decided that that's actually total rubbish. The whole publication is evidence-based, and we've worked hard at that. And those of you who work in academia anyway will know that our evidence base is still fairly poor. And many people have been talking about that for a long time and done their very best to build on that evidence, and let's continue to do so. It's peer-reviewed. The peer review process has been very robust, as it needs to be if we're going to use the publication in the way that we should. People volunteered to be peer-reviewed. Sometimes we had far too many for particular chapters and not enough for others. So sometimes we looked for peer reviewers directly. Sometimes we had tons of people who wanted to participate. But the HOP series and many other publications, to include all of those from National Back Exchange, set a standard for best practice in the UK, and hence for the courts. It is internationally known, and BackCare hope that this publication will also be internationally known. Who knows? The world is getting smaller, but travel is less, and people tend to be back working in silos a little bit. Who's it for? I think this is our biggest question. Just from my own profession, from physiotherapy, there's 55,000 members of the Chartered Society of Physiotherapy. And to a degree, they all touch and handle people. But how many of them know about our evidence base? And how many of them know about the HOP series that sets a standard? I would say probably the same for the Royal College of Nursing, the same for the College of Occupational Therapists, the same for ergonomics and human movement. There are many areas where we're just not getting the message far enough. We use it as a basis for training, but do we ask down the line people to use it more, managers, educators? So there is aim from BackCare to attempt to broaden that area. But yes, primarily we set that standard. We are the ones that get the message out. So movement and handling practitioners and trainers, needs assessors, risk assessors, decision making, budget holders. Where do they get their ideas from? Where do they get a standard from? And is there a standard? Policymakers. All staff working in health and social care and emergency services, educators, universities, providers of further education. The legal profession, expert witnesses. I come across, I'm sure others do too, expert witnesses talking about movement and handling issues who have really no basis on which to form their opinion or evidence. Potentially, every user of health and social care. Now, if we're going to get our message out there, then we have, I'm sorry about the cliche, have to sing from the same hymn sheet. Well, do you know what? This is the only hymn sheet we've got, together with all the other publications that we produce. These are our hymn sheets. So let's try to support that process. Okay, so what's in it? It's a person-centred document. And I'm not going to repeat that. Well, I probably am going to repeat that for some reason for every chapter, which is a good thing. So chapter 1. This is about using the law as a tool to support decision-making and defending professional good practice. This is written very differently. So this is not, this is the law and a list of dates and names. This is how to use law and good practice guidance in order to inform and then make decisions, and then, when necessary, defend those decisions. Michael, who most of you know well, or a lot of you have heard speak anyway, refers back to 2003 in his introduction to the chapter. And he praises National Back Exchange in 2003 for the title to that year's conference. Anybody remember? Which was Humanising the Load. That sounds like person-centredness to me. He praises Back Exchange and says that that decision at that time was inspired. It was inspired to humanise the load and make things more person and patient-centred. It's very easy to say person-centred care. It's very hard to do. He's revisited his chapter, and as I say, he now has case law from the Coronavirus Act, which was about a challenge to an assessment of a person, a community assessment of a person that was carried out remotely. And this was challenged as an inadequate assessment. That failed. The judge said it was preferable to have the face-to-face assessment, but given the priorities of the day and the whole situation taken into consideration and the success of the virtual assessment, which I think is important, he said that actually it was an adequate assessment, which I think will stand us in good stead a little bit in some services going forward, as long as those assessments are done thoroughly and are suitable. And you'll see all of that in Michael's chapter. So all new legislation since the last edition, 2011, 10 years, and there is quite a lot. I mean, even the Care Act was 2014. So there's quite a lot changed in the legal and in the responsibilities. He talks about the relationship of duties between the CQC and the HSE. He talks about safeguarding in relation to formal and informal care delivery. He talks about blanket policies, and which can create unlawful fettering of discretion, which has always been a lovely phrase. So it can limit the person-centred decision-making. He covers case law looking at the psychological, emotional and dignity issues, person-centredness. He looks at direct payments, issues of capacity, best interest decisions, issues of restraint. Much more case law than ever before, over a bigger scope. That's chapter 1. Chapter 2. This is a system in a nutshell. So this is about the development of person-centred policies and what that means. So the elements that make up that system and the synergy between them. As we all know, the most important thing is that an organisation, however big or small, has a policy about its moving and handling. And that their training programme, whatever that needs to be, is in line with their policy. And then what happens on the shop floor every day, what happens with every person, has to be what happened in the training room and what's written in the policy. Now, I know that sounds very simple, But actually, how many of us, hand on heart, can say that happens? So we start by defining person-centred care and how that fits into balanced decision-making. Now, balanced decision-making has been on the cards for a long time and includes, of course, safety to the person being moved, staff safety, rehabilitation opportunities, and all areas of choice and dignity. We do not want to water down staff safety. Don't for 1 minute think that person-centred care puts staff at risk. But in any one case, we need the talent, the information, and the evidence to be able to decide, in any case, is one of those 4 areas slightly more important than any of the others, and how do we make that decision? This chapter also addresses the impact of the Francis report in 2013, following the mid-staffs case, which changed ultimately the role of the CQC. We look at policy development and how this applies in many settings where movement and handling of people occurs. We look at training systems. Training needs to be suitable and sufficient, or adequate and appropriate, whichever way you look at it. And that's what we need to demonstrate. And the remote delivery of training, the use of mannequins, the change in approach in the way that we've done things and adapted really efficiently over the last 18 months will produce studies which will inform us going forwards. We weren't able to find any robust studies about detail of the success because it's just too soon to evaluate whether it had any major difference on patient satisfaction or feedback or on staff safety. It then goes on to look at training required for the competent person. What do we need to do to empower those decision makers? That's not a training delivery for new staff, induction staff, or regular refresher training. This is training for practitioners who make those decisions. And sometimes, in some areas, it's the wrong person that makes the decision. We look at equipment systems and how they fit in. And we look at cultural change and the synergy between that practice and that policy. Cultural change is tough, isn't it? We heard from Jackie this morning, and I'm sure it was a fabulous presentation. I enjoyed every moment of it. But we could have heard that some years ago. Where have we moved? Why are we not making progress? Why are we still looking at situations in some wards where we haven't made a difference? Let's hope we can learn from this week, and move forward. Chapter 3. Now, I don't know whether Mike is in the room. Are you in the room, Mike? He is. Forgive me, Mike, if I'm summarising this slightly inaccurately. Chapter 3 is an overview of the ergonomics and human factors. And it replaces the separate sections in previous editions of ergonomics and biomechanics, which have been separated, and what Mike, again, more than once, uses the word balance. He says that with all applications of ergonomics and human factors to health and social care scenarios, there is a need to balance the effects, risks and benefits between the carer, the person receiving care, and the organisation responsible for that care delivery. And Mike looks at all of those to find advice for practitioners looking for that balance. Mike revisits worker safety, where organisational systems have improved. There are systems of equipment provision and training, but we heard the groans. Compliance, adherence to best practice still remains a challenge. And you all agreed with that when Jackie was talking this morning. Mike then goes into detail for the ergonomics methods toolkit and looks at, in much more detail, task analysis, anthropometry, postural analysis, physiological and biomechanical methodology, and subjective appraisal. I'm pretending I know all about those, but of course I do, because I've read his chapter. Evidence gathering is key to delivering high-quality person-centred care, to understand and support our complex decision-making. And that's where we need to focus. We need to focus on evidence gathering in order to maintain and improve. Chapter 4. And I think Julia is in the room. She is. Oh, very close to Mike. That's a bit worrying. Okay, so chapter 4 is the central topic. This is the glue. This is what holds everything together. This is what joins theoretical and practical chapters. It covers the why and the what and the how of person-centred risk assessment, which in itself is ambitious. It explores the real application of both person and handler-relevant evidence-based tools to measure such things as the posture of the handler, the anthropometrics of both person and the handler, the force required, the comfort, and the feedback, all leading to a synthesis to provide a solution and then testing that solution. This chapter looks at decision-making pathways and documentation and fits together with the ergonomics approach of chapter 3, the detailed policy and competence requirements of chapter 2, and the legislative background of chapter 1. So the 4 chapters together form the underpinning knowledge. In addition, of course, there is still some very cogent stuff on biomechanics and detailed ergonomics in both HOP5 and HOP6, which does not need repeating. Chapter 5 is a big chapter. They're all big chapters, but this is a big chapter. And chapter 5A is the introduction to those practical chapters. Now, throughout all the editions of the handling of people, the practical guidance sections have always been the ones that are probably the most referred to. The problem is that people thumb through the practical chapters and look at pictures and don't read all the accompanying text. And we can't do anything about that because all the background information, all the evidence gathering is there to support the decisions. This time, the format and construction is slightly different, well, very different, with 2 major changes. There's a much, as I've said already, there's a much closer focus on person-centred care. The needs and choices, involvement, inclusion of the person being moved in those decision-making, and an enabling approach. So a bit more enabling, some rehabilitation to promote function and levels of independence. There is, secondly, a real attempt to underpin all the guidance with as much supporting evidence as is currently available. Other sources of practical guidance, the clinical skills, the NBE books, all of which are referenced and pulled together. It's really important that that hymn book is in synergy. Academic literature, of which there is quite a bit, but on certain topics there's a lot, and on other topics there's none. And occasionally, where appropriate, We draw on equipment manufacturers' recommendations and some of the evidence they produce. The evidence has been very clear, scrutinises the best we can. The overall structure is task-based and is a toolbox. So, for example, let's think about the movement from sitting to standing. Then we would follow a patient ability from an independent FIM score of 7 or 6 to a more dependent FIM score of 1 or 2. And within that one topic of from sitting to standing, you think about your person that you're making a decision about, and you decide where in that toolbox or skills or ideas that person might sit. They might be improving, they might be deteriorating, or they might be maintaining their level of movement or mobility or independence. So you would find that level. So you can go all the way. So in a sit to stand, that might go from just a verbal prompt to a ceiling track hoist with a harness or others, and many other things in between. Then you might go on to another task. So let's talk about a non-weight bearing, non-hoisted transfer. So you would start with someone who could manage a transfer board with very little help, or even completely independently when no one was around. A non-weight bearing, non-hoisted transfer would take you all through the range of abilities to a pat slide for 3 or 4 people in an operating table. So you're looking at a transfer from every ability before you move on to the next movement. I don't know whether I've explained that well enough. Well, you'll have to wait and see when you open the book. Importantly, and this was a huge decision and a very long discussion. Remember my P's at the beginning: personalities, people, perceptions, promises. So very long discussion as the evidence boxes. Do you remember all the evidence boxes? And many of you would have been involved in that. Were we going to redo the evidence boxes? Were we going to trust the evidence from before? It was the very same transfer. Were we going to decide to get rid of the evidence boxes? It was a very difficult decision. And if we were to have that discussion in this room now, it would go on for hours. And we'd ended up with a vote and it would be split. So it was a difficult discussion. And in the end, what we decided, what we looked at was, how valuable were they? Well, they were an indicator, but an indicator of that person with ability at that time, with those handlers, in that perfect environment, in order to produce a figure that was going to be published. And that's not really real life, is it? That's not how things happen. We are all different anthropometrical shapes, sizes, we're all different abilities, we're all different. The beds are different, the chairs are different, the environments are different. So how can you say that one particular technique, a sit to stand with one person, always has a REBA score of? You can't. But they were an indicator, and they did teach people that those are the things they should be thinking about. So you can see that this discussion goes round and round. However, the combination of the ergonomics chapter and the risk assessment chapter and the explanations elsewhere, hopefully will empower people to do those measurements for themselves in their situation. Not saying, oh, well, actually, that's an easy technique because that only has a REBA score of. So we're not sure how well those evidence boxes were used or even understood. That in itself is another question that's very difficult to answer. So they don't appear in the practical chapter. Wait for it. They do come in a little bit later. So there isn't those boxes everywhere. The decision to rely on the increased volume of published and peer-reviewed articles as evidence justifies, I think, the selection of the techniques we chose or the methods that we chose. Now, as people become more and more experienced, then when they have a situation, they slightly adapt what they know is a recognised method, and they adapt it to meet the person they have in front of them. And of course, that's fantastic. That's what we need to do. We need to adapt what we know. We need to justify that. We need to communicate that. We need to say, with this person, this is the best way in this situation to get them to their bathroom. So hopefully, the practical chapters are those toolboxes. There are many variations listed, and also it allows individual practitioners to make decisions for themselves based on the toolbox of skills without saying, this is what you should do and this is what you shouldn't do. So if we have a workshop session where everybody's doing some practical, and I'm sure attendees both at the exhibition stands and in the sessions today and tomorrow will be doing that. You'll be sharing what you do. Well, this is the way I do it. Now, there is good things about that, and then there's lack of evidence. And so it was a juggle between what we did have evidence, solid evidence for, and what were recognised good practice, and what was variations and almost permission for people to devise solutions based on evidence principles, if that makes sense. So that was the part of the rationale behind the practical chapters. So within each practical method, so each task is then broke down into methods and all sorts of things like subtasks. And then there's a standard method and a variation, and many variations to give people opportunity to think for themselves. If you're going to put a shelf up and you're going to take your toolbox, there's an awful lot more you need to know. And when you open the toolbox, you have many solutions. And that will depend on the type of shelf and the type of wall and what you have available. And we hope that in the practical chapters, that's the sort of toolbox you'll face. But in each method, there is a very repetitive set of considerations. So for each method, we look at the context and reasoning behind that. So maybe we look at the background literature that supports the task described as we describe it. We look at a review of current guidance. Then it includes a context description, the why, the where, the when, that prescribed task might take place. We then look at the personability, takes the reader through the task by reference to the FIM score of the person taking part. We then look at the environment and equipment considerations. There is a growing range of equipment, and has been, for some while. It's really important to say that this is not an equipment handbook. It absolutely is not. Equipment is mentioned, but it's fairly generic in the way that it's mentioned, because it isn't supporting any particular manufacturer, it's not supporting any particular piece of equipment. Although from some of the images, equipment will be recognised, but not necessarily as that bit of kit endorsed. It's more about this principle of equipment will achieve this task. Oops, sorry. there's certainly not only one way to do something. We describe them in the methods and variations. We describe quite detailed the actual, what we would call a standard method, and then we describe the various variations, and then we have a list of what other things you might consider in order to change that variation, should that be pertinent to your case in your situation. I've been in court a couple of times where people have tried to argue that if something wasn't in the book, it couldn't be done. And I'm sure other people have too. Or that if it was in the book and described in this particular way, the person who was doing it in that particular way was automatically wrong. When there might be a really good reason why the person had changed that in order to adapt to the circumstances. So we're hoping that this will be a little more thought-provoking in that direction. So in the precautions and the considerations, then we look at all the task methods there may be, and we look at specific hazards, dangers, or triggers that need to be identified and addressed when coming to a solution, things you have to think about. And I have to echo what Jackie said this morning about bed frames, because certainly the positioning in a bed is very much dependent on the type and style of the bed mechanisms. Okay. I'm going to come to the end of this far too quickly. 5B is all the weight-bearing tasks. So that takes us through everything that we do take weight for. But that might be someone with a very low FIM score who is relying on hoisting equipment to take their weight. So just because it's weight-bearing doesn't mean there's no equipment. And 5C is the non-weight-bearing section. But just because they're non-weight-bearing doesn't mean they're not independent. So it's a slightly different format and way of looking at it. There will be things that are missing because we're people with personalities and promises. But we hope with the sufficient peer review process that we've gone through that we have captured most things. But it does allow for continued variation and development on behalf of an experienced practitioner. So what's brand new in this publication is Chapter 6. And Chapter 6 is the case studies chapter, which has been an absolute pleasure. It's the first time I've used that P, isn't it? It has been a pleasure. And it's been a pleasure because the people who have submitted case studies have done so with such commitment to their area of specialty. So let's think about what those case studies have. The ones that, and I have to say, there were case studies submitted that didn't make it. And that's not because the editorial team decided they weren't good enough, or it's just because it's about the balance of the book, it's about the style of the book, it's about repetition, it's about having areas in that are wide and broad enough. So if you happen to submit a case study and then it hasn't made it, or it didn't make it because you will know that, then there will be opportunity. Present it at conference. Do something with your case study. So the first one, very swiftly, timely, reactive to that P, the pandemic, is the proning and management of critically ill patients during COVID-19. Now, we were very lucky to get this case study, that sufficient evidence and thought had gone into this. This is from one of London's largest hospital trusts that is over 4 or 5 sites and employs 16,000 members of staff. They grasped the proning issue very early. They had a very high level of COVID patients. They deliver their COVID proning training over 1 to 2 hours with 10 people in each session. And then they have shared with us the content of that training and the evaluation and feedback. And like with all these case studies, they're a model for how you might solve not the same problem, but a similar problem. Oh, that was a good idea. Haven't tried that, even though you might be thinking about something quite different. The methodology in each of these case studies is each different, but will form a blueprint for some of you for some issues that you face. So they've shared, as part of their case study, their lesson plan, the detailed method for proning. So that is why proning does not feature in the practical chapters, because they were the experts, they did their study, so we published it as a separate case study. (6.2), so our second case study, looks at hoisting in the community. And it looks at ceiling track versus mobile, 1 person versus 2 people. Now, this is not as simple as it sounds. And ultimately relied on person-centered decision-making. Surprise, surprise. But it's an interesting study that has been published, and we're very grateful to Sarah for sharing it. Case study 3, and I notice on the programme there is a presentation about this very topic from somebody else tomorrow. This is about that grey area between moving and handling and restraint, clinical holding, whatever you want to call it. And one of the problems is the variety of terminology. This looks at holding technique for a side lying in order to deliver personal care with a combative person. So this is something that manual handling people over the year, oh gosh, no, that's restraint. And restraint, whatever you want to call them, people said, well, you just hold them. And actually there has to be some level in between. So this describes and evaluates a static hold and measures it that can be used when an essential hygiene activity is required. Of course, you go through all of the decision-making beforehand, all of the ways of managing that challenging and aggressive behaviour. This is the final line, if you really have to intervene. It talks about that. The terminology is difficult: clinical holding, positive handling, supportive holding. But from April 2021, so now a little few months ago, any organisation inspected by CQC that uses and describes any of these restrictive practices is required to commission that with training providers that comply with their set of standards. And I would urge manual handling practitioners who work in any of those controversial areas to familiar yourself with those standards and talk very closely with anybody who delivers any form of clinical holding training. You need to be a team. So it's a very interesting case study. Case study 4 is about working at low level, and we heard Jackie again this morning talk and mention the manual handling challenges of leg ulcer dressing. This was a study done by Carol, and she talks about community nurses carrying out leg ulcer dressings. She looks at the observation, task analysis, the strategies for managing that, and then advice and action. And advises that sometimes you only need small changes in order to improve an outcome. 5, early mobilisation, another hot topic. And we can see in the exhibition hall the number of companies that are tackling the area of early mobilisation. The use of equipment to get people up sooner, not the end of the line for somebody who now needs a transfer by equipment. The first line in intensive care to improve people's mobility. The first line, just to get them sitting on the side of the bed or into a vertical position. Please concentrate on early mobilisation. We're not there just to move people, we're there to help them improve themselves. So another great case study. Number 6, nearly there. Number 6 was Sharon's story told by Penny. And Sharon's story is about a young lady at school who had difficulties with a toileting regime. That talks about the risk assessment, the analysis, the risk assessment process, the design of solution, the carrying out of the solution, and the evaluation of the solution. And in Sharon's case, it was hugely successful. Are you seeing the pattern? Person-centered to Sharon, that solution wasn't going to necessarily meet everybody's needs. But the examples used will help you devise your own. 7, the leisure activity. This is about helping someone into a boat in a wheelchair. And this was, again, a very successful event, eventually. Good risk assessment, good design of a solution, good carrying out the solution, good measurement, and a fantastic solution for the young lady who went in the boat for the first time. I suspect she's been there many times since. It's great to read it. It's great that enablement and that sort of empowerment is part of our new way forward. And the final one was a care pathway for pregnant ladies of plus size. And this shows, again, a risk assessment, a definite way forward and a care pathway, solutions discussed ahead of the game, equipment provided and made familiar ahead of the game, training delivered for people in readiness, standard operating procedures for use in the future, feedback, evaluation. And they've shared with us and are published as appendices the forms and the screening tools that maternity department used. So, that takes us to the end of HOP7. Wow, gosh, I wish it did. That takes us to the end of the content of HOP7. I do hope that, one, you're not too upset if you weren't involved. I do hope that you're very proud if you were involved. I do hope that you look forward to it and that we use it to complement all the other publications that NBE and others, so that we can find that hymn book of solutions that we share with all professionals who handle people in any way, shape or form. Because other than that, we're going to work in a silo of talented manual handling practitioners. We need to lead the way with our own professions: nurses, OTs, physios, carers, support workers, learning difficulties staff. Oh, and I don't want to miss anybody out. Everybody else. And that's not to lump you all together. Whatever I say, I'm going to get it wrong. All of us. So it's been a long time coming. And I do hope that when it is finally published this year, at the end of November, it will be a Christmas present. It'll be a Christmas present for us, that's for sure, when we can relax and think finally that it's a job well done. Thank you very much.
Thank you very much, Pam. We had a conversation a while back about the process of going through the production of a book. And I was very empathetic with the stresses and everything you were having for the completion of that. And that's high on my Christmas list, I have to say. In fact, it's the only thing on my Christmas list at the moment. Has anybody got any questions for Pam? Anybody?
None?
Okay, that's great. Just thank you very much again, Pam. That was fabulous.